Hello everyone and welcome. I'm Dr. Asim Hussein and I'm glad you're here today. We'll be discussing the management of traumatic brain injury. This presentation will cover key aspects of how we approach and treat this serious condition. Over the next few slides, we'll explore the latest strategies, challenges, and best practices. Let's get started. All right, let's focus on this clinical scenario. We have a 40-year-old male involved in a road traffic collision, presenting with a Glasgow Coma Scale score of 7, which indicates a severe head injury. His GCS breakdown is E2, V2, and M3, meaning he's opening his eyes to pain, has incomprehensible sounds, and flexes to pain. He's also agitated and vomiting, which complicates the situation further. The CT head is still pending, so we need to act quickly to ensure his airway is protected. When considering the options here, it's crucial to prioritize securing the airway given his decreased consciousness and vomiting, which pose a risk of airway obstruction and aspiration. Among the choices, the most appropriate immediate management is endotracheal intubation with cervical spine protection. This approach allows us to secure the airway definitively, prevent aspiration, and protect the cervical spine. Less invasive options like high-flow oxygen or non-invasive ventilation might not be sufficient in this scenario because of his level of consciousness and agitation. Delaying airway management until after the CT isn't safe, given his current condition. And a nasopharyngeal airway alone simply wouldn't provide enough airway security in this situation. So, in summary, the key point here is that with a patient who has a low GCS, vomiting, and potential cervical spine injury, definitive airway control with endotracheal intubation and cervical spine protection is the most appropriate immediate step. Let's take a look at this important point. The correct answer here is C. When a patient's Glasgow Coma Scale score is 8 or less, it indicates a severe level of impairment. In such cases, intubation becomes mandatory. The primary reasons are to protect the airway and to ensure proper oxygenation and carbon dioxide removal. It's also crucial to remember that during this process, full cervical spine precautions must be maintained to prevent any additional injury. This step is vital in managing severe brain injuries and aligns with our overall goal of safeguarding the patient while providing the necessary intervention. All right, in this scenario, we have a patient with severe traumatic brain injury who's been brought into the ICU and is on ventilation. The key points here are the blood pressure, heart rate, and oxygen saturation. The blood pressure is 85/55 mmHg, which is quite low, and the heart rate is elevated at 120 beats per minute. The oxygen saturation, however, is good at 98% on FiO2 of 0.5, so oxygenation seems adequate for now. The main concern here is the low blood pressure. In a patient with severe TBI, maintaining adequate cerebral perfusion is critical. If blood pressure drops too low, it can compromise blood flow to the brain, increasing the risk of secondary brain injury. Therefore, correcting hypotension is the most urgent priority. While other parameters like hyperglycemia, hypercapnia, fever, or anemia are important in the overall management, they don't demand immediate correction as much as ensuring stable blood pressure does in this context. Remember, stabilizing hemodynamics is often the first step in managing critically ill neuro patients to prevent further brain injury. So, among the options, the physiological parameter that must be corrected most urgently here is the hypotension. All right, let's look at the key point here. The correct answer is B now, moving on to the explanation. Hypotension, which we define as a systolic blood pressure less than 90 millimeters of mercury, is particularly dangerous in patients with traumatic brain injury. In fact, it doubles the risk of mortality in these patients. That's a significant increase, and it underscores how critical maintaining adequate blood pressure is. Preventing secondary brain injury is our top priority because the initial injury is just part of the problem. What happens afterward can be just as damaging if not managed properly. Ensuring good cerebral perfusion by avoiding hypotension can make a real difference in patient outcomes. So, in the context of trauma care, paying close attention to blood pressure and acting swiftly to correct hypotension is essential. This is why managing blood pressure effectively is a core part of our approach to trauma and brain injury treatment. Now let's look at this case. We have a 55-year-old man with severe traumatic brain injury, a GCS of 6, which indicates a severe injury. The CT shows cerebral edema and a midline shift, suggesting increased intracranial pressure and potential herniation risk. So the question is, what's the most appropriate next step? Let's go through the options. Starting with option A, immediate decompressive craniectomy for all patients. While this can be life-saving in certain cases, it's not something we do immediately without further assessment and stabilization. Option B, starting steroids. Historically, steroids were used in brain injury, but recent evidence shows they're not beneficial and may even be harmful in traumatic brain injury, so this isn't recommended. Option C, inserting an intracranial pressure monitor, is a key step here. Monitoring ICP helps us assess the severity of intracranial hypertension and guides further management decisions. It's an essential part of managing severe TBI with signs of increased pressure. Option D, hyperventilating to lower PaCO2 below 30 mmHg routinely, is a temporary measure. It can reduce ICP quickly, but it's not a definitive treatment and shouldn't be used routinely due to risk of cerebral ischemia. Finally, option E, observing clinically only, is insufficient in this scenario. Given the CT findings and GCS score, we need active intervention rather than just observation. In summary, for this patient, inserting an ICP monitor, option C, is the most appropriate next step. It allows us to objectively assess intracranial pressure and tailor our management accordingly. This step is crucial in the overall approach to severe TBI management, ensuring we act promptly and appropriately to prevent secondary brain injury. The correct answer here is C. Let's talk about why that is. ICP monitoring, which stands for intracranial pressure monitoring, is particularly indicated in patients with severe traumatic brain injury, or TBI. Specifically, when the Glasgow Coma Scale score is 8 or less, indicating a severe injury. It's also important when the patient's CT scan shows abnormalities. The main purpose of ICP monitoring in this context is to guide therapy, meaning it helps us make informed decisions about treatment. And most critically, it helps us prevent secondary injury, which can occur if intracranial pressure rises unchecked. So overall, ICP monitoring is a key tool in managing severe TBI cases to improve outcomes. All right, let's focus on managing a traumatic brain injury, or TBI, especially when intracranial pressure, or ICP, gets dangerously high. Now, in this scenario, the patient's ICP readings are persistently over 25 mmHg, and their Glasgow Coma Scale is declining, which signals worsening brain function. So what's the most appropriate first-line intervention here? The options include high-dose corticosteroids, mannitol or hypertonic saline, immediate decompressive craniectomy, profound hyperventilation, or hypothermia to 32 degrees Celsius. While corticosteroids have been used in some brain injuries, they're not recommended for TBI because evidence shows they don't improve outcomes and might even cause harm. Hyperventilation can temporarily lower ICP by constricting blood vessels, but doing it aggressively or prematurely can reduce cerebral blood flow and cause additional brain injury, so it's not the first step. Now, decompressive craniectomy is a surgical option for refractory ICP, but it's typically considered after initial medical management fails. This brings us to hyperosmolar therapy, mannitol or hypertonic saline, which are frontline treatments to rapidly reduce ICP. They work by drawing fluid out of the swollen brain tissue, helping to lower pressure promptly. So in this case, the most appropriate first-line intervention is B, mannitol or hypertonic saline. This approach can stabilize the patient before considering more invasive procedures. It's crucial to recognize these priorities to prevent further brain injury and optimize outcomes. The correct answer here is B. Let's break down why. Osmotherapy, which includes agents like mannitol or hypertonic saline, is actually the first-line treatment when we're trying to reduce elevated intracranial pressure acutely. These options work quickly to draw fluid out of the brain tissue and help lower the pressure. On the other hand, steroids are contraindicated in this scenario. While steroids can be useful in certain brain conditions, they are not appropriate for managing increased ICP, especially acutely, because they don't effectively reduce pressure and can sometimes worsen the situation. So the key takeaway is that in cases of acute ICP elevation, osmotherapy is your go-to initial intervention, and steroids should be avoided. This aligns with our overall goal of prompt and effective management to prevent further brain injury. Now, let's consider the question about hyperventilation in a patient with TBI who is experiencing acute neurological deterioration and suspected critically elevated ICP. The key here is understanding how hyperventilation fits into our overall management. Hyperventilation causes a decrease in carbon dioxide levels in the blood, which leads to vasoconstriction of cerebral blood vessels. This vasoconstriction can temporarily reduce intracranial pressure, making it a useful short-term measure. However, it's crucial to emphasize that hyperventilation should not be used routinely long-term. Overuse can lead to cerebral ischemia due to reduced blood flow. Therefore, the correct answer here is that hyperventilation is a temporary rescue measure only, used in specific, urgent situations to buy time until definitive treatment can be provided. It's important to connect this to our broader management strategies. Hyperventilation is not a first-line therapy, but an emergency tool, and should be used judiciously to avoid causing additional harm. The correct answer here is C now. Let's talk about why. Hyperventilation might seem like a quick fix in some situations, but it actually causes cerebral vasoconstriction, which means it narrows the blood vessels in the brain. This narrowing can reduce blood flow even further, potentially worsening ischemia. So, while hyperventilation might seem helpful at first, it's important to remember that it should only be used as a short-term rescue measure. Relying on it long-term could do more harm than good. This is a key point in managing patients with cerebrovascular issues, emphasizing that we need to be cautious with interventions that affect cerebral blood flow. Let's look at this question about cerebral perfusion pressure, or CPP. We have a patient with a severe traumatic brain injury, a MAP of 70 mmHg, and an ICP of 25 mmHg. The question is, what is the optimal CPP target in this scenario? Remember, CPP is calculated as MAP minus ICP. So in this case, it's 70 minus 25, which gives us a CPP of 45 mmHg. Now, considering the options on the table, the best answer would be the one closest to this calculated value. That would be the option indicating a CPP of 40 to 50 mmHg. This range is critical because maintaining CPP within this window helps ensure adequate blood flow to the brain without risking further injury from excessive perfusion pressures. So the key takeaway here is that in patients with elevated ICP, like in severe TBI, we need to carefully target CPP, generally around 50 mmHg, to optimize cerebral blood flow and prevent secondary brain injury. This concept ties into our overall goal of balancing perfusion and intracranial pressure to improve patient outcomes. Let's take a look at the correct answer, which is E. When managing patients with traumatic brain injury, it's crucial to target a cerebral perfusion pressure, or CPP, in the range of 60 to 70 millimeters of mercury. This range helps us maintain adequate blood flow to the brain, ensuring it gets enough oxygen and nutrients to function properly. At the same time, we want to avoid pushing the CPP too high, because that could potentially worsen cerebral edema, leading to increased intracranial pressure. So, the key is to find that balance, keeping CPP within this target range to support brain perfusion without exacerbating swelling or other complications. This approach aligns with the overall goal of managing intracranial dynamics carefully to optimize patient outcomes. All right, let's look at this question about seizure prophylaxis in a patient with severe TBI and cortical contusions seen on CT. The key here is understanding that cortical contusions increase the risk of early post-traumatic seizures. So the question is, what's the best approach to prevent these seizures? Now, looking at the options, we have no prophylaxis needed, long-term anticonvulsants indefinitely, benzodiazepines only, short-term anticonvulsant prophylaxis for about a week, or steroids to prevent seizures. From the evidence and guidelines, the most appropriate choice here is short-term anticonvulsant prophylaxis, typically around 7 days. The reason is that seizure risk is highest in the first week after injury, especially with cortical contusions, but long-term anticonvulsants aren't necessary unless seizures actually occur. Choosing no prophylaxis or long-term therapy isn't supported unless there's a history of seizures. Benzodiazepines might be used acutely, but aren't recommended for ongoing prevention. And steroids, while useful for reducing edema, don't prevent seizures. So the best answer here is D, short-term anticonvulsant prophylaxis for about a week. This strategy helps minimize early seizures without exposing the patient to unnecessary long-term medication risks. It's a targeted approach aligned with the overall goal of managing secondary brain injury effectively. The correct answer here is D now. Let's talk about what that means. Short-term anticonvulsant prophylaxis, such as levetiracetam or phenytoin, given for about 7 days, has been shown to reduce the risk of early post-traumatic seizures. This is an important point because preventing seizures in the immediate aftermath of a traumatic brain injury can significantly impact patient outcomes. The key takeaway is that administering these medications for a short period can provide a protective effect during that critical early phase. This approach aligns with our overall goal of optimizing recovery and minimizing complications after brain trauma. All right, let's look at this question about adjunctive therapies for a patient with severe traumatic brain injury. The question asks us to identify which intervention is contraindicated in this scenario. We have 5 options here. A head elevation to 30 degrees, B, osmotherapy, C, early nutrition, D, corticosteroids, and E, normoxia and normocapnia. Now, starting with head elevation, elevating the head to around 30 degrees is actually beneficial because it helps reduce intracranial pressure by promoting venous drainage. Osmotherapy, like mannitol or hypertonic saline, is commonly used to control increased intracranial pressure as well, so that's generally appropriate. Early nutrition is important in severe TBI patients to support healing and prevent malnutrition. Again, this is a standard part of management. Normoxia and normocapnia, maintaining normal oxygen levels and carbon dioxide, are critical because hypoxia and hypercapnia can worsen brain injury, so these are also recommended practices. That leaves us with corticosteroids. Historically, corticosteroids were used in brain injuries, but evidence has shown they are actually contraindicated in severe TBI because they don't improve outcomes and can increase the risk of complications like infections or hyperglycemia. So in this context, the intervention that is contraindicated is D, corticosteroids. Remember, always base your management on current evidence, especially in critical care settings like this. The correct answer here is D, and the key point to remember is that corticosteroids actually increase mortality in patients with traumatic brain injury, or TBI. Because of this, they must not be used in these cases. It's a crucial concept because, despite some historical use, evidence has shown that corticosteroids do more harm than good in TBI patients. So always keep in mind that their use is contraindicated in this context. And this ties into the overall theme of understanding proper management and avoiding interventions that could worsen patient outcomes. Today, I want to highlight a core principle in managing traumatic brain injury. The outcomes for patients largely depend on preventing secondary brain injury, not just treating the primary insult. What does this mean? Well, while the initial injury is crucial, It's the secondary processes, like swelling, ischemia, and increased intracranial pressure, that often determine the overall prognosis. So, our management strategies need to focus on intervening early and effectively to minimize these secondary injuries. This approach aligns perfectly with the overall goal of improving patient outcomes by protecting the brain from further harm after the initial trauma. Let's go through the primary survey for traumatic brain injury management, following the ATLS guidelines. First, if the patient's GCS is 8 or less, intubation is essential to secure the airway and ensure adequate ventilation. This helps prevent hypoxia, which is critical because maintaining a PaO2 above 80 mmHg is necessary to protect the brain from further injury. Moving on, we need to avoid hypotension, aiming to keep systolic blood pressure above 100 to 110 mmHg. Proper perfusion is vital for brain recovery. Then, it's important to perform a rapid neurological assessment to understand the extent of the injury and monitor changes over time. Lastly, ensure the patient is fully exposed for thorough examination, but always take measures to control body temperature, as hypothermia can worsen outcomes. Keeping these steps in mind helps us manage traumatic brain injury effectively and improve the patient's chances of recovery. Let's take a closer look at the ICU targets that are crucial in managing traumatic brain injury. First, we aim for an intracranial pressure, or ICP, of less than 20 to 22 millimeters of mercury. Keeping ICP within this range helps prevent further brain damage caused by increased pressure. Next, cerebral perfusion pressure, or CPP, should be maintained between 60 and 70 millimeters of mercury. This ensures adequate blood flow to the brain without risking hyperperfusion. We also focus on controlling carbon dioxide levels, with PaCO2 kept around 35 to 40 millimeters of mercury. This helps regulate cerebral blood flow and intracranial pressure. Normothermia, or maintaining a normal body temperature, is equally important because fever can worsen brain injury. Additionally, blood glucose levels should be kept between 6 and 10 millimoles per liter. Too high or too low glucose levels can negatively impact brain recovery. Overall, these targets are part of a comprehensive approach to optimize brain conditions, minimize secondary injury, and improve patient outcomes. Remember, close monitoring and adjusting these parameters are key in managing traumatic brain injury effectively. Let's talk about the stepwise management of raised intracranial pressure, or ICP. First, elevating the head to about 30 degrees is a simple yet effective way to promote venous drainage from the brain, helping to reduce ICP. Next, ensuring the patient is adequately sedated and analgesed is crucial, because agitation or pain can increase ICP, so we want to keep the patient calm and comfortable. Then, we consider osmotherapy, using agents like mannitol or hypertonic saline, which work by drawing fluid out of the brain tissue and into the bloodstream, decreasing swelling. If the patient has an external ventricular drain, or EVD, CSF drainage can be performed to directly remove excess cerebrospinal fluid and lower pressure. In some cases, temporary hyperventilation can help by reducing carbon dioxide levels, leading to vasoconstriction and decreased cerebral blood volume, which can temporarily lower ICP. Finally, in refractory cases where other measures aren't enough, decompressive craniectomy may be necessary. Removing part of the skull allows the swollen brain to expand outward, relieving pressure and preventing further injury. All these strategies are vital in managing traumatic brain injury, aiming to stabilize the patient and prevent secondary brain damage. When it comes to managing traumatic brain injury, there are some therapies we definitely want to avoid. First, corticosteroids. Many people think they might help, but evidence shows they can actually be harmful in this context, so we should steer clear of them. Next, prolonged hyperventilation. While hyperventilation might temporarily reduce intracranial pressure, doing it excessively or for too long can decrease blood flow to the brain and cause more damage. So, it's important to use it cautiously and not as a routine. Then, there are hypotonic fluids. These can actually worsen cerebral edema because they lower serum osmolality, leading to increased swelling in the brain. Overall, these are key points to remember because managing traumatic brain injury requires careful, evidence-based approaches. Avoiding these therapies helps us prevent secondary brain injury and supports better patient outcomes. Now, let's talk about seizure management in traumatic brain injury cases. The key point here is that prophylaxis should only be administered for 7 days. This means we typically give preventive treatment during this period to reduce the risk of early seizures, but we avoid extended use to prevent unnecessary side effects. Next, it's important to treat clinical or electrographic seizures aggressively. If a seizure is observed, whether it's showing obvious signs or only detected on an EEG, we need to respond promptly and decisively. Effective seizure control is crucial because ongoing seizures can worsen brain injury and complicate recovery. Connecting this to the overall theme, managing seizures effectively is a vital part of traumatic brain injury care because it helps minimize secondary brain damage, supports better neurological outcomes, and ensures that we're providing comprehensive, targeted treatment during the critical early phase. Now, let's talk about some key aspects of managing traumatic brain injury. First, nutrition and support are crucial. Early enteral feeding, when possible, helps maintain gut integrity and supports overall recovery. It's important to start feeding early to prevent malnutrition and promote healing. Next, DVT prophylaxis should be considered once it's safe to do so. Preventing deep vein thrombosis is vital because these patients are at increased risk due to immobility and other factors. Stress ulcer prophylaxis is also an important part of the management. The stress of a brain injury can increase the risk of gastrointestinal bleeding, so medications like proton pump inhibitors are often used to reduce that risk. Overall, these supportive measures, nutrition, DVT prevention, and ulcer prophylaxis, are integral to improving outcomes in traumatic brain injury patients. They complement the primary neurological care and help set the stage for recovery. Let's review some key pearls for ICU management of traumatic brain injury. First, hypotension is particularly dangerous because it can significantly worsen brain injury and increase mortality. Maintaining adequate blood pressure is critical. Next, a GCS score of 8 or less indicates a severe injury, and in these cases, intubation is usually necessary to protect the airway and ensure proper ventilation. It's also important to note that steroids, which were once commonly used, have been shown to actually worsen outcomes in traumatic brain injury, so they should generally be avoided. ICP-guided therapy, on the other hand, can be life-saving. Monitoring intracranial pressure allows us to tailor treatments precisely to prevent secondary brain injury. And while hyperventilation can temporarily reduce ICP, it's really just a bridge, something to buy time in acute situations, but not a definitive solution. Overdoing it can cause harm by reducing cerebral blood flow, so it must be used cautiously and in conjunction with other therapies. Altogether, these principles highlight that careful, targeted management is essential for improving outcomes in traumatic brain injury. Thank you all for your attention and engagement today. I truly appreciate your time and interest. I hope the insights shared have been valuable and have helped to deepen your understanding of the key concepts we've discussed. Remember, the ideas we've explored here are meant to inspire and guide your efforts moving forward. If you have any questions or would like to discuss further, please don't hesitate to reach out. Thank you once again for being a part of this presentation.